they'll call us and they'll say, hey, we can't identify any reason for this patient's pain. We think it's out of proportion with the physical exam and with all of our workup. We're concerned for some sort of psychogenic component or non-organic overlay.
Okay.
And so, like, the really, I guess, crummy interpretation of this is saying, like, hey, we don't think this patient should be in as much pain as they're claiming they are, and we think it's all in their head.
Yep.
Therefore, psychiatrists, can you come see them?
Hello, and welcome back to another week of Calling in Sick. I'm your host, Alex Wilderson. It is Mental Health Awareness Month, and the moon was in Sagittarius, which meant we all had a shitty week last week. So I think this episode is going to be pretty topical, and hopefully it feels like some free therapy, because I walked away from it feeling like I had just had free therapy. And it felt that way because I brought a psychiatrist in to be my guest this week. You might know him from Instagram. It's Preston Roche. He's hilarious. He blends education and humor to help all of us understand mental health a little bit better. But in this week's episode, I wanted to dive into pain in mental health, because most people with chronic illnesses do that nice little tango with pain at some point, whether that's acute or chronic. And the implications that pain has on our brain for our mental health is unavoidable. So in this episode, you'll get to hear a conversation where we talk about how pain is taught in med school and what it's like moving from the classroom into in real life, and what it's like moving from the classroom to in real life scenarios dealing with patients with chronic pain. But personally, I think the most interesting thing about this episode is to hear the patient perspective and the provider perspective in pain management. But I don't want to give it all away, so give it a listen and let me know what you think. But before we get off to the races, quick housekeeping as you know I do, please follow, like, and subscribe, and send this to somebody in your life that you know struggles with pain. And because pain just sucks and we all need some self-care when we're dealing with pain, I've got some Alex picks for you guys this week. First and foremost are warmer times. These are little sticky heating pads that you put on the bottom of your socks. It's like a hug for your feet. I put these suckers on when I was traveling to Penn for my clinical study last week, which I will fill you guys in on next week, don't you worry. Game changer. My feet were hurting so bad. Link in the description below. My Raynaud's girlies. These might be what you've been looking for your entire life. My second pick of the week is the Sage Extra Strength Pain Relieving Oil Blend. I know some people totally knock essential oils and whatnot, but this truly does help me with my pain, especially that mechanical, crunchy joint pain that we get when there's thunderstorms and shit like that. So if you're looking for a little bit of pain relief and you want to try something new, this is a great topical option. Link in the description below. Now, without further ado, I hope you guys enjoy this conversation with Preston.
Hey, welcome to Calling in Sick. I'm Preston. You also know me as Presro on Instagram.
I thought that was your
I'm a psychiatry
real name.
resident. No, my real name is Preston.
No, it's Presro.
But you can call me Presro.
That's how I emailed you.
So today we have a guest, which is me. And actually, Elizabeth was telling me how she was... Oh, Alexandra. I'm so fucking sorry.
It's okay. You're Presro. I'm Elizabeth.
Yeah, you just gave me like Elizabeth vibes in person.
It's my past life.
Okay. So...
It's prednisone me.
That's why. That's the only... Alexandra was telling me how much she hates doing the intro, so I offered to do it today.
It's very kind.
Okay, and so we have some lovely topics that we're getting into. We're going to be talking about chronic pain.
We are.
We're going to be talking about psychiatry.
We are.
And everything in between. We might even get some sailboats or existential dread. We're both drinking Olipop, so who knows what's going to happen at this point.
And full of existential dread as well.
Okay, that's all I have for the intro, so turning it over to you.
Oh, thanks so much. That was a wonderful intro. Best I've ever done. It's phenomenal, actually. I'm now going to make that a stand for every single podcast. You've started something new. You're an innovator, Preston. I mean, Presro.
I mean, innovation isn't new for me, but
no,
this
just
is.
for me. Tangent and side note, when I reached out to invite you to be on my podcast, I thought your name was Presro, and that's what I put in the email. I was shocked that you responded to me.
People call me Presro all the time. It's actually
from?
it's a conjunction of my first name and last name.
I haven't heard someone use the word conjunction since middle
what's,
school.
What's your function, really? So it was like midnight, and I was like, Preston Roche. That's my full name. I was like, Pres Ro.
You are an innovator.
Kinda
Wow.
Works. Yeah. Well, so Halsey, who I listen to a lot, I love Halsey.
Only when she's depressed, though.
Yeah. Well, she makes better music when she's depressed, but Halsey, if you're listening to this, I'm so happy you're happy.
Yeah, we love you. She's autoimmune, I'm pretty sure.
Yeah, and bipolar.
Yes.
So overlap. Oh,
There's overlap.
You know, it's like she's the third person in the room right now.
Halsey, if you're here.
Anyways, her name is an anagram of Ashley, which is her government name.
Wait, what?
Yeah. Her actual name is Ashley. And if you rearrange the letters in Ashley, it makes Halsey.
We're really doing a throwback to middle school English.
And I was a bit inspired by that. And I was like, okay, I want to do something. I was actually thinking about doing Esto or Eston.
I like that too.
I just felt a little douchey.
Okay, I also had another idea for your name. It's currently on Instagram. It's Press Row. It's why haven't you done like the Sabrina Carpenter?
Oh, I get like
Presso.
Yeah, it's Mia Espresso.
Yes.
Yeah. Some people have suggested that.
You're welcome.
I
was the first one that suggested it, actually.
And what's wild is I do like espresso a lot.
Is that your coffee version of choice?
I actually had an espresso shot this morning, but I usually make...
How many?
Just one. So, like, I think everyone learns to find their caffeine of choice in medicine.
Yes.
And so, like, I was actually thinking about doing a series on, like, what specialty prefers what type of caffeine. So, like...
Yes.
Like, plastic surgery... derm, it gives like very like Celsius vibes, and like you'll find them like
totally agree.
downing those in the hospital.
Yeah.
But then OB-GYN for some reason, Diet Coke all the way. Like,
yep, I see that.
They crush Diet Coke nonstop. Emergency medicine, Monster.
Yes.
As you probably guessed.
I was going to say cocaine on that one.
Yeah. And then like I've seen a mix of them because there's a lot of different like prototypes of humans that come to IM.
True.
So you have the pencil case girl type. All the T's are crossed, all the I's are dotted.
Yes.
She uses like different color pencils for each like note, like multicolored
borderline
pens.
OCD.
Yeah. So like those people have like Celsius a lot of times.
Yes, for sure.
But then there's also the white monster 0-calorie bros.
Those are pretty good.
I am too. Yeah.
That was my drink of choice in investment banking.
And then Psychiatry's coffee.
Just straight up like black coffee.
It's like black coffee, so you can fetishize your solitude and.
Can we talk about how you use whole milk in your coffee?
Oh, it has protein.
Gains. Okay, now everything is making sense.
Yeah. So every morning I log it. I'm like, okay, I had a whole milk latte with 6 ounces. And
that's breakfast.
It's 5 grams of protein. Easy money.
Who needs a smoothie when you're having whole milk?
Yeah. Exactly.
Honestly, that's why I didn't get you a coffee. Because you said whole milk.
You don't want me to be too powerful.
No. I was like, that's just too much power. Okay, so we were going to chat a little bit. I got completely distracted right there on which direction we were going to go. But I wanted to talk to you about med school, which you're no longer in. So this might be really hard because, it's been time has passed.
Yeah.
But if you can take yourself back to that day.
Okay,
close your
rolling
eyes.
The clock back.
Envision yourself day 1 of med school. Someone says chronic pain. What are you seeing?
So
they're passing around.
First of all, this is kind of like you're doing like psychoanalysis right now.
I'm actually a therapist.
I should be in a recliner doing this. So when you're describing this, I'm picturing myself in a lecture hall. There's probably about like 150 people.
Okay.
It's actually when I learned I needed glasses because I couldn't see the screen.
That's why I got glasses too. I realized I was blind.
I have an astigmatism. I'm farsighted, I guess.
Twins.
So I remember we had a couple pain lectures, and everything at the beginning, like I went to UNC and they did a great job of kind of working towards like patient advocacy.
Okay.
So a lot of it, the lectures we got were about how you need to like believe pain when it's presented to you. And
that seems like a good place.
Yeah.
To start.
And everyone was like in agreement with that. So like we would have kind of these even like vignettes on our test where a patient comes in, they've been addicted to opiates in the past. They have an opiate use disorder, but it's a car crash. And it'd kind of be like, they're asking for something to control their pain. What should you give them? And the answer is always give them opiates. Like people with substance use disorders can have accidents too, and they can also have pain that still needs to be managed.
Very true. Very true.
At the like didactic level, the first time I was introduced to it was kind of in this, I think, well measured, like in somewhat idealistic way. And I think that was the purpose of the textbook, and it was in a way a departure from kind of how things were even like 15 years ago, where
I think so.
pain was kind of hailed as this like fifth vital sign.
There's been so many different like variations of training of what pain has looked like. I think pain a vital sign, then pain's been overprescribed, and now pain is real and should be listened to.
Yeah.
We love that pendulum swing.
And then you leave the classroom and you go join the hospital, and things get a little bit different.
Okay.
So when you are rotating as like a third year medical student, so you've kind of taken your initial licensing exam and you're in the hospital and you're working on a part of a team. Now you're dealing with real patients that don't neatly fit into these boxes you got in the lecture hall before.
Yeah, like at all.
Yeah, and it turns out they have feelings, and people on your team have feelings, and things start to clash.
Yes.
So we would... sorry, this Olipop's gonna make me burp.
I did that also on purpose. I had to put you like a little off your kilter, you know?
Okay. So like we would go into these rooms, and like the patient is like frustrated. They're mad at us for not controlling their pain. And then
yes.
I'm like, I think, we like, can we give them like a Dilaudid drip? Like I feel like that they're asking for like the
more pain control.
Yeah, the pain controlled pump.
Yeah.
And then like the resident or the attending would be like, this is obviously like pain-seeking behavior, and they're like frustrated with them, and like they're not going to improve at all.
Yep.
And then you realize it becomes this like back and forth, and like the team would have this feeling that the patient doesn't have a desire to get better, isn't trying to improve at all, and they're just trying to use everything as a means to obtain this pain medication.
Yes.
And the patient's like clearly uncomfortable.
The patient's like, I am trying to get a means to the end of this fucking pain.
Yeah, exactly. And I think it was hard to balance that dialectic, because if I'm in this position where all I want is the pain to stop, and I've identified that this medication is going to do that, like, why wouldn't I ask for more of it? And a lot of times these are people that like can't understand all the implications about like why this medicine may not be helpful.
Yes,
and
agreed.
And to clarify, so like opiates specifically, they completely slow down your gut, so you can get really constipated.
Like always.
Yeah, and they also don't do a great job of treating non-cancer pain.
Interesting.
Compared to like other modalities that we have.
Wait, tell me more about this.
Yeah, so when in a study that looked at I think it was like musculoskeletal or like arthritic level pain.
Okay, yeah.
Yeah. They took Tylenol and ibuprofen combined, and then they took like oral opiate medications, and things like oxycodone. And they found that the Tylenol and ibuprofen was just effective, if not more effective in some scenarios, at treating this like musculoskeletal pain.
I actually totally agree with that. Like my musculoskeletal pain, narcotics don't super touch that. Mm-hmm. Tylenol and Advil, yeah.
The problem is narcotics can be helpful with coping with it, because you can get euphoric responses. Yeah, and you also learn to associate taking that medicine with relief of your pain. So there's a placebo effect superimposed on the medicine. And like you have like the true effect of the medicine, and then you have placebo. And I think a lot of what I do is I try to kind of shift that expectation over to other medicines. So what I found, like in these scenarios where the team is at odds with the patient, and the patient's like, I just want my pain to go away, the team's like, oh, they just want these specific meds, is I try to kind of play salesman, and I pitch other things. I love this. So okay, pitch me. I just did. I told you, and you convinced me. God damn, ibuprofen you're good. And Tylenol, yeah. And then I'll say, the other thing I'll say is, I know you said Tylenol doesn't help for your pain, right? I'm like, the thing about Tylenol is it's really bad at chasing pain, but it's good at preventing pain. Yeah. So what you gotta do is you gotta take it every day at the same time, like it's a multivitamin. Yep. And I was like, and that's just our baseline. So we'll start there, and then we can start to work on other things to augment our pain. Yeah, that's fair. That's absolutely fair. And so like, if I can get them excited about that, like I almost like, I try to like reinvent the relationship with Tylenol a little bit. Which I think like, you have to do. I know we're doing that, but like we just got to take it consistently. Even if you're not in pain, take it at the same time. Because there's a lot of good studies supporting like scheduled Tylenol. So then the kind of tension starts to open up a little bit. It's not, I've identified this as a solution, you're trying to push me away from the solution. Because nothing sucks more than that, TBH. Right. we've opened up the playbook of different solutions, and now we can kind of come alongside you and work together to figure them out.
I love that approach because I think more often, and I got to say, I think you're kind of unique because in most of my hospitalizations, I think I've gone in and usually it's the first conversation of, God, she's definitely pain-seeking. Like, she has CRPS. She knows what all these different pain meds are. Like, blah, blah, blah. And at the same time, I'm like, yeah, I do. I do know what all these different pain meds are because I have CRPS and I've taken all of them. I know what works for me. But I think it's usually like when a specialist comes in, sits down with me and is like, let's chat about all these different options. Here's what you've tried. Have you tried this? Have you tried this in combination with this? Like, let's give that a go and see what happens. And also, like, the breaking down of here's the why behind it all, I think is super important. If you don't understand the why as a patient, then I think it's just as like, you're not fucking listening to me.
Yeah.
And there's nothing worse than that when you're sitting in a hospital bed, you can't get out of bed because you're in so much pain and you're like, great, this is yet another experience like this.
That's absolutely so true. I found the best way to validate someone's experience in these scenarios is to give them insight into your reasoning.
Yeah. Why do you think some people don't do that?
Because in order to do that, you have to teach, and teaching is really hard.
It is really, yeah, that's fair.
Like, teaching it's an empathetic process where you have to try to use a lot of times like quips and analogies to take someone who doesn't have a history of medicine and make this complex, nuanced information palatable for them. Yeah. It's really hard. And there's been times where I try to explain stuff and I'm like, I'm way too esoteric right now. I'm in the weeds and it's going over their head. I'm like, shit. But then I also don't want to be like reductionary and be like, this bad, this good. You know, like that's not helpful either.
No. But like finding the in-between definitely is. Do you think that there is we were talking about it a little bit earlier, but like the cohorts of different age groups of doctors and specialists where they learned medicine and pain management in a certain way that has made them not want to do that with patients?
Yeah, and you see it even in like the language they use. Yeah. So especially in psychiatry. Yeah. So older doctors, especially from like even like I think prior to the 90s, if they did their training, will be less afraid to use terms like addict.
Yes.
I guess that's like not something that like we try to use anymore in the hospital at all. And in the context of like person-centered language, we say like this is a person with a substance use disorder or alcohol use disorder or even like abuse as far as like for a substance. We try to get away from saying that too, because to say you're like abusing opiates or like abusing a substance, it's like, well, you're using it to cope because at the end of the day,
you're in pain.
Yeah, or emotional or physical pain.
True,
and
totally.
Whatever substance you're using it's a failed way of coping.
Yeah.
And so you're not abusing it, you're
coping.
Just misusing it. It's a use disorder.
Yeah, yeah. I like that.
So like I think framing it like that is like kind of very helpful because once you've called someone an addict, you then dismiss the need to treat that.
Yes,
aspect
100%. And I think that has actually compounding effects on patients, where then like me as a patient walks away and goes, well, should I be taking a pain medication right now? Am I in pain enough for that? Am I an addict if I take this? And then you like have this whole mind fuckery of, do you deserve pain relief? Which is wild.
Yeah. Have I earned the right to take my pain medication by suffering? And the way you earn it is by suffering, right?
100%.
So you're measuring yourself and saying, have I suffered enough?
This is a conversation I have with myself.
Yeah.
Regularly.
So have you suffered enough?
I don't know. Am I a huge wimp?
Maybe.
Probably.
Yeah.
Probably.
I mean, you're drinking an Olipop.
This is my medicine of choice.
Cheers to that.
Cheers to that. How do you think patients can get through that kind of like psychological barrier of bearing kind of like society's coinage of if you take pain medication, you're an addict or you have a problem or you don't deserve to take the pain medication?
So
I'm asking for a friend.
Yeah,
clearly.
I think this is something I struggle with too, which is just my identity and our identity. And remember that we we in a lot of ways are our actions, but we never end up being like a specific noun that is our actions.
Okay.
So even if like someone in layman's terms would be an addict, you could say they have an addiction.
Yeah.
So this is just like one aspect of me. But then as far as like saying like, okay, if I take this medicine consistently, or if I feel like I need it or can't cope without it,
Yeah.
am I not worthy? Well, I would say like worthy of what? How do I define my value? Is it from the amount of suffering I'm willing to tolerate? Like, okay, maybe resilience is important to me.
Yeah.
But you kind of have to reframe, what does it mean to be resilient? Does it mean to suffer unnecessarily from something that's preventable? Or does it mean to like find a way to overcome hard things and accomplish like what's in line with your values?
I love how you're phrasing that. I think that allows people to take the jump of, do I deserve to take this medication, to I am worthy of being pain-free.
Yeah.
And that's huge.
Yeah. And also like, I am not more or less worthy if I tolerate my pain with or without medicine.
Yes. And the whole,
like it's completely divorced from my worth. This is about me addressing in discomfort that I have.
Yes, 100%. I also find that a lot of people with chronic illnesses and like autoimmune diseases in general are, and this is very much an overgeneralization, super type A. You want to be your doctor's favorite patient. You want to like be gritty. You want to be resilient. You want to be all of these things that people are telling you, man, you're so tough. You're an inspiration for getting through this. And you're like, will I break that part of my identity when I've already lost so much of my identity to this disease or to this whatever? Can I make that jump then? So I think I don't remember where I was going to go with this, but somewhere on this line, I think it's interesting that like people struggle with these different labels in order to decide what they're going to do with their disease management.
Yeah. So that's interesting. You want to be like an A+ student in your disease management?
100%. Yeah. I want to be an A+ in how I manage my disease. I want to be my doctor's favorite patient. They know like she's doing everything she can to get better. And like, I've got to optimize every single day to get better. And that's been like something I've had to really work on breaking out of my identity, that like health is it's not a game. It's not a race. It's like every single day there's just little things I have to do. If I do them, I will feel better. If I don't do them, it doesn't mean I failed that day. Just meant that wasn't in the cards for that day, and that's okay. Like stripping that away from your identity.
Yeah. Is that something you see in like other patients with chronic pain too?
Yes. Very, very much. And not just chronic pain, but like chronic illness in general.
Oh, interesting.
I think it's because we spend so much time with doctors. And so when you finally have a doctor that listens to you and says like, you are sick, then you're like, oh man, I've got to be that person's best patient because they're finally listening to me.
Wow. So this is something I've never gotten to hear a patient perspective on. Have there been times where you start to worry or perceive that your doctor is frustrated by you or doesn't like you?
Oh yeah.
What is that like?
Awful. Oh my God. I get like so much anxiety. And I find that I have that not in appointments all the time, but if you send a portal message and then you like layer in the lens of whatever day you're having and interpreting what that portal message says. Like I remember at one point, great example, I was just taking Cellcept, and that is a pretty intense immunosuppressant. I've been on it before. I was able to tolerate it before. This time I had within 48 hours.
Is that like mycophenolate was?
Yeah, okay. Exactly. Within 48 hours developed debilitating depression, like passive suicidal ideation. It was awful. Pinged my doctor for the first time. I've been sick for 25 years. First time in my life said, I don't think I can do this medication. Like, I can't handle this. Yeah. And her response was, that's not really a common side effect of this medication. Let's try to keep going. And I was like, why isn't she listening to me? Is she pissed off at me? Like, am I disappointing her that I can't wrestle through the symptoms of this? Like, this is a me problem. And then I took a step back and I was like, no. Let me just stop taking it for a day and see how I feel. And within 24 hours, lifted. Like, completely lifted. No depressive episode. And then I realized my doctor's not pissed at me that I want to not take this medication. I'm not being non-compliant. I'm just relaying facts to her, and she's responding to those. And that, I think, was really difficult at first because I was already in this depressive state. Yeah. And then moving through it, she said, okay, that's fine. And it resolved. But that was hard for me to think this doctor who had been working with me for so long and like had seen me grit through so many things all of a sudden might be disappointed in me.
Yeah, that's interesting. So like from a doctor's perspective, I think, you know, if a patient tells me about a side effect that I'm not familiar with and they're convinced it's associated with the medication, I think it's common to have a similar response. Like, hey, I was taking this medicine and I noticed, you know, it caused me like a lot of chest pain or something. And I think my initial response might be like, well, you've taken the medicine for 2 days and there are a million things under the sun that can cause chest pain.
Yes.
And I know that this medicine can be like very helpful, so I wouldn't expect it to be associated with it. So let's keep trying.
Yeah, totally.
And also I can see how that comes across as invalidating if you're like, oh, I know.
Yeah.
Trust me, I know.
And like as chronic illness patients, I will say like we know our bodies pretty damn well after a certain point of time. Like if you're just starting, maybe you're learning the ropes to pick up the signals. But at 25 years, I'm like, I know what's going on at this point, I think. But yeah.
Yeah, like you're almost like a separate tier of patient that is pretty calibrated to how you respond to different pain signals and side effects and things.
Which
like
is good and bad.
And I think like it's funny that phrase, I know my body, it feels like, I feel like it rides with, I also have a high pain tolerance. Those two phrases tend to be, they irk people in the medical field.
Okay, tell me more.
So if somebody says like in the emergency department, I have a high pain tolerance, I think it's very rare I've seen evidence of high pain tolerance, I guess. and I think like that this becomes like a reinforcing bias, and maybe something like I can work on or other people can work on, where it seems like people are trying to legitimize their discomfort, or like trying to like, let me show you how uncomfortable I am because you're not seeing like evidence of it. And
you don't know me outside of this one situation.
Right.
Yeah.
And then I think the I know my body kind of, it almost can imply like some complacent reasoning, I think. And that's interesting. That can be, I think, what is frustrating to doctors.
That totally makes sense. And on the, I have a high pain tolerance, I want to double click on that because I've heard myself say that before. And what I realized just like randomly one day, I was sitting down in a lot of pain and realized I don't have a high pain tolerance. I actually can't tolerate pain that well. Like it breaks me to my soul. But I can endure a lot of pain for a long time. But those are two really different things, I think. And when patients go into an ED setting and they're like, hey, I have a high pain tolerance, and then it takes a ton of pain medication to get them to like a normal spot, that is not a high pain tolerance. That's, you can endure a lot of pain.
Yeah. And I think like the easiest thing to say is like, hey, like I'm tough and I'm willing to endure a pain. And just leave it at that.
Totally agree.
Because it seems like when you say like I have a high pain tolerance, it's a lot of times attached to a request for more pain medication.
I think so too.
And I think that like those things can get subconsciously coupled, maybe not out of malintent on like the physician or the provider side, but
it seems
it's almost become of like like a hackneyed phrase for that.
I think so too. And I think the other thing too is I realized, my dad helped me realize this, who I've told you about, he's a surgeon, is that a lot of people with chronic pain, your body negotiates with pain differently than other people. And what that means is that, yes, you can endure a lot of pain, but you also might need a pharmacy bag of pain medication to like get you down to a normal spot in those episodic moments. And that's okay in those moments, but it's not okay for every single day forever. Yeah,
absolutely. And so weirdly enough, I think what I've probably responded to best, and what I think other providers may respond best to, as simple as it is just like, I'm trying.
I like that. It humanizes it.
Yeah, I'm trying because I'm trying too. Like, and I think what a lot of people are trying to convey when they say I have a high pain tolerance is I'm trying to do my best to deal with this pain.
And I couldn't handle it by myself anymore. And I need your help now.
And so, and I think that's like the best way to set up the doctor-patient relationship is to say, I'm trying my best and I need help.
Yeah.
And then from our side, we're trying our best and we'll try to help you. And like, I think that's the subtext of what a lot is said with these phrases, but it gets misinterpreted when it crosses the line.
Yeah. And I think patients come in with that phrasing too, because you have so many times in your life with your disease where you feel like you have to prove your pain, or that you haven't been believed, or whatever. So that's like an armor people put on.
Yep, absolutely.
And it's okay to take off that armor. I think you get better treatment when you're just being human and like really vulnerable.
Yeah, and it sucks because there are people who get their pain dismissed, but when they try to prove their pain, they get lumped in with people that maybe are misrepresenting their pain.
Yes. How common is that, would you say? Like misrepresenting your pain, or actually like drug seeking versus experiencing actual pain?
So I know you put like one on one hand and one on the other hand, but they live on a spectrum with each other.
Fair. Totally fair.
So there are people that like they are experiencing real pain, and then they, you know, maybe will misrepresent that pain in order to like
actually get the treatment that they need.
Yeah. Obtain drugs or substances. I think.
Yeah, because I think usually it's like you go in and you say, I'm in pain, and it's like, oh, let's try Tylenol. And you might have experienced this so many times where like, yes, that will take me down 0.5% of my pain, but that's not going to do that much. So then you have to like almost oversell your pain, which is also fucked up. But like, I think that's why it happens.
Yeah. So I can't put a frequency on it because I never know if someone's drug seeking or not. Like you'll never find that out for sure. Like nobody leaves the hospital and goes like, surprise.
I was faking. I got you
the whole time. just for your records, I want you to know this was all bullshit.
You've
like
been punked.
Yeah. So at the end of the day, like I try my best to like accurately assess someone's discomfort and help them with that. And to be like clear for anyone listening, I'm a psychiatry resident, so I've had internal medicine rotations where you treat people who maybe their primary issue is pain on an inpatient hospitalization. But as far as like a lot of my pain treatment goes now, it's in conjunction with like mental health and their other symptoms around that. I'm very rarely in these like ED settings where I'm doing this kind of stuff. So everything I'm retelling you is like experiences that I've had as an intern and things like that. But in those situations, my philosophy has kind of been like, I'm not like the grand gatekeeper of all opiates or other pain medication, and I don't think it's going to be like make a giant difference in the grand scheme of things if I like support this patient's pain right now. And I think some people, they get indignant because they're like, I think this patient's trying to dupe me, so I'm like not going to give them any pain medication. I'm like, I don't know. Like it doesn't come out of my pocket. Like I don't lose life points for doing this thing. And I know if it's not me, it's someone else. So if something that's ends up being like an olive branch to help us get down to the true source of the problem, maybe this is me thinking about it as a psychiatrist, because if someone's drug seeking, they have pathology. It may not be the pathology they're telling us it is, but,
that's fair.
But they have other issues that we can kind of investigate, and a lot of that will come from like having rapport with them. So
that's really interesting. Let's dive into that more. So tell me, if someone is potentially drug seeking, where do you try to like, I guess, where's your attachment point then? So
I mean, I guess the first foothold is, what do opiates do for you?
For me?
No, that's what you asked them.
Oh, I was like, I mean, sure. Let me tell you.
Well, we can start with you. Yeah, what do they do for you?
They definitely help bring down pain. Not always, though. I think there's also like, when I'm in an acute period, way more helpful than in a chronic period. Because at a chronic point, we know this happens. Like your body grows a tolerance to it, and you don't really like notice that much of a difference, unless you stop taking them all of a sudden, and then you're like, oh fuck, my body has become dependent on this medication now, and I'm in a shit ton of pain.
Yeah, you go through the withdrawal.
Yeah.
Gotcha.
Yep, and then have usually a rebound on the acute episode.
Mm-hmm. So if we were in the hospital setting, I would say, so opiates, I guess in a sense, save you from times when you're in crisis.
Yeah.
They're your fire extinguisher, and it sounds like you're in crisis right now, so I think it's pretty reasonable to want to save that crisis.
Yeah, that does seem reasonable.
And now where like maybe you may be labeled as drug seeking, maybe you're not in a pain crisis, but you're like in an emotional crisis. And,
yes.
And you want to go back to that same thing that you know helps solve you when you're in that crisis.
Yeah. Yeah. And then I think that emotional crisis, like that is usually a trigger. It's an emotional stress trigger. Mm-hmm. And that causes my autoimmune symptoms to then skyrocket.
Gotcha.
So you can't even separate them. It's actually one thing I wanted to chat with about. Traditional Chinese medicine, there's no separation of mind, body, soul. Mm-hmm. Western medicine, we break it up. We bifurcate everything. But when we do that, then it causes this issue where like, okay, so if you have emotional duress, that can't have impact to physical mm-hmm. duress and vice versa and vice versa. But I think what you're saying is like maybe there's changes going on in how medicine's being taught that's saying, no, we're going to address it as together.
Mm-hmm. Yeah, I think mind-body dualism is on the way out.
Yeah.
Yeah. So I guess back to what we were saying about like how to find these footholds with your pain. I would say, I guess in that scenario, a part of you feels like nothing could get you out of crisis.
Yeah.
If it weren't for these opiates.
Yeah, and I think there's a lot of fear wrapped into it. Mm-hmm. A lot of fear, because I know what not controlled looks like, and it's like passing out, having seizures, like mm-hmm. pain that rocks and ruins your day, week, month, whatever.
Yeah. So opiates are what's standing between you and your worst fear
at
this point. Yeah.
During pain crises, for sure.
Mm-hmm. So, I mean, from this like small interaction, we've identified that in this pain crisis, this person mm-hmm. has identified and latched on to this idea that opiates are their only option for them.
Yeah.
So, and now we can say, I guess this is more like a CBT question. How do you know opiates are your only option?
That's a great question. I think it is experience before ever trying opioids and trying to manage pain and not being able to control it.
Yeah.
Versus adding that to my toolbox and being like, oh, that turns the dial down.
Yeah. So what evidence do you have that opiates are the only thing that work?
I've tried other medications and they weren't able to turn the dial down. So like we can look at the nerve medications box, mm-hmm. gabapentin, nortriptyline, all of those. And those do work eventually, but the time it takes from crisis to working mm-hmm. is unbearably long.
Okay. So we have basically other medications that are less helpful.
Or can be helpful, but not immediate relief.
Gotcha.
And I think usually if I'm at the point where I'm seeking immediate relief, I've been in the space of, am I tough enough? Like, I got to keep trying to grit through this. I can do this. And then it's like, oh, shit, I've had a breaking moment. I no longer can fucking do this.
Yeah, exactly. Yeah, it's really interesting. So I think kind of like in this like mini scenario, mm-hmm. it's about identifying that person's relationship with their medicine. And what it usually ends up being is it's a way to alleviate distress, either like emotional or physical.
Absolutely.
And then I think you kind of just try to explore all the ways that they negotiate their distress.
Yeah.
And I think that's the best place to start. This is all super idealistic because most of the time in like these actual inpatient settings, people are reasonably not interested in hard change.
No, I think at that point, like you want to just be comfortable.
Absolutely.
And you want to do what you know makes you comfortable.
Mm-hmm. But I think like it can plant seeds for maybe
future?
Months later when they follow up and kind of try to figure out how they want their coping to look.
100%. I actually had my like last large hospitalization was a CRPS flare that then like spiraled. Well, rewind. It was a CRPS flare that spiraled into like a massive I call them meltdowns. I have let things go on for too long at that point. And I was in the ED. They then admitted me. The primary care team that was helping me did not believe that I could possibly be experiencing the amount of pain that I was experiencing. Got super frustrated. By the grace of God, palliative care came in and like interjected. And it was that interaction that not only one helped me get to a comfortable spot because pain was finally controlled, but also they sat down and like chatted and educated me on like, hey, these are the different tools that are out there. Right now, let's use this tool. But in future, like, let's discuss what else is out there. Mm-hmm. And that was a game changer for me.
Yeah. Palliative care doctors are like the Kevin Durant's of agenda setting in the clinical setting.
Yeah.
They are so good.
So good.
And like, I
Calm.
think so much of palliative care is like really effective communication.
Yeah, I agree.
And like, yeah, I mean, I've rotated with them a few times, and like I learn a lot for them that I like use in psychiatry and vice versa. So I've actually thought about doing a palliative care fellowship.
No way.
I don't think I will, but
I feel like you'd be good at it.
thank you.
In this like conversation right now, the way that you talk about pain and like are curious about it and open-minded, like that's kind of what makes a good palliative care doctor, in my opinion.
Yeah, they're very efficient at kind of saying the hard thing and then coming alongside people.
Totally. And not just to the patient, but I also think to the team attending.
Yeah.
Which is cool.
It's a lot of like liaisoning.
Yeah.
Which psychiatry does that too, just usually not necessarily like a pain context.
Let's dive into psychology a little bit. What's that like in an inpatient setting when there is a patient dealing with pain, but there is an underlying understanding that like there's probably something else going on that is anxiety, stress, depression, psychosis, blah, 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 blah.
Yeah. So this is a phrase that you'll see a lot, or I guess we see a lot, is like psychogenic pain or non-organic overlay. Those are the two things that people will say.
Okay, so layman's term for both of them.
Yeah, so psychogenic means like psycho, like your mind, or I think it's like the Greek for soul, and genic is in Genesis, so it's coming from the mind.
Okay.
So it's in their head.
Got it. And
non-organic overlay is the same way of saying like, or organic in this sense means like from the body. So there's no identifiable source of pain from the body where this is coming from.
Got it.
So it's another kind of like tongue-in-cheek way to say I think this is in their head. So a lot of ways that like we'll get this consult in psychiatry is they'll call us and they'll say, hey, we can't identify any reason for this patient's pain. We think it's out of proportion with the physical exam and with all of our workup. We're concerned for some sort of psychogenic component or non-organic overlay.
Okay.
And so like the really, I guess, crummy interpretation of this is saying like, hey, we don't think this patient should be in as much pain as they're claiming they are, and we think it's all in their head.
Yep.
Therefore, psychiatrists, can you come see them? I don't think that all people that like make that call have that opinion, but like I think that's like the most negative way to view it. I think another thing is to say, hey, like pain is complicated and we can identify bodily sources of their pain, but we want to treat their pain. Can you help like do a full assessment of their like psycho contributions to it? Because pain falls within the biopsychosocial model.
Totally.
So, and that's usually how we try to approach it. So
it was like the pain reprocessing therapy perspective.
Yeah, exactly. And I was just reviewing some of these papers on the way over. And if someone is like depressed in the hospital, how they interpret pain is actually fundamentally going to be different. So
escalates it.
Yeah. So it turns out that in your anterior cingulate cortex, so
where on your
cingula, so if you look at my head from the side, your cingula kind of like curves around, it abuts up right against your prefrontal cortex, which is like your big thinking part. So it's like kind of like right in here.
Okay.
This portion we find has decreased activity in depressed patients, or we think it does.
Interesting.
And it's kind of one of it's near some structures that we target with magnetic therapy. It turns out that this same region is also heavily involved in pain processing.
Interesting.
So without trying to make too many complacent conclusions about this, we know these two regions are intertwined. And what we find is that when people are experiencing depressive episodes, their subjective ratings of pain change.
Oh, yeah. Mine skyrocket through the fucking roof.
Yeah. And so we have this like perceived somatosensory, almost like pain amplification.
Yes.
That happens.
Yes.
And what's interesting too is that it will specify to certain types of pain.
Ooh.
Because you can't just use the word pain and then kind of like lump in discomfort. You have different nerves that sense different things.
Right. That makes sense.
So like in your fingertips, you have like alpha nerve endings, beta nerve endings, delta nerve endings, and they'll tell you different things. Okay. So like, for example, if I brush my finger gently along my finger, that's a certain type of nerve ending. But if I were to touch something hot, there's a whole different set of nerves that sense temperature.
This makes a lot of sense. Okay,
so light, touch, and pinprick. And then there's also things like vibration or proprioception, which is like where it is in time and space.
Yes.
So these go along, these go along different tracks. So one of them is called like your spinothalamic tract. A lot of this is processed in your thalamus, and then almost like how much it's amplified may be affected in the cingulate cortex that we talked about.
Interesting. Okay.
So all that's to say is someone who's experiencing maybe like burning or tingling pain,
like that neuropathic.
Right. Exactly. That may be amplified more or less or in a different way than someone who's experiencing like mechanical, arthritic, aching pain.
Totally. And those, I think, have two very different endurance abilities for patients.
And I guess the paper I was reading was saying that that mechanical pain is amplified more by depression.
I'm trying to think back in my time.
Than the like depressed. Burning, tingling pain. But I think it affects kind of your tolerance of all of them differently.
Would agree with that for sure. Yeah.
So this makes it very interesting for us when we're like, okay, my goal is to treat someone's pain, so I can try to target the actual source of discomfort directly, but also I can target you and how you frame it and handle it.
Right.
So almost in a way, I think about sometimes if I can treat their depression, that will
build a bridge.
Indirectly treat their pain.
Yeah.
Right. So something like Lexapro wouldn't nominally be a pain medicine, but if you use it to elevate someone's mood and put them in a better place, they're more equipped to cope with that pain. And then it kind of functions as one.
That kind of brings it back to like, how much can you tolerate it? If you're in a better mood and a better headspace, you can endure something a little bit longer.
Exactly. If you're anxious about something being painful and anticipating it, it's going to be more painful. And what we know is that like SSRIs can help alleviate some of that anxiety.
Yeah. Yeah. I was looking at, or had a chat with the pain reprocessing therapy out in LA last year. And we were discussing like turning the dial down. How do you actually do that? And like, does that work? And I think it does, especially when that pain is being amplified by depression or anxiety.
Yeah. And so this is another funny paper I read about like how we modify or classify pain. They did a study where they had people curse when they experience pain. Like they would just yell like "fuck" or make up new curse words, and their subjective pain scores were better than people that didn't. And so it's like we all know that feeling when you stub your toe and you're like, "son of a bitch."
Yes.
But there may be some science that like it's effective. Yeah. And like, I mean, weirdly enough, like we know, like we do it because it feels better.
Yeah.
You know? Like,
it's like crying. If after your cry, sometimes you feel better.
Yeah. So it's like people know what helps. And then a lot of it is us just discovering afterwards.
It's almost like a hormonal release, which then kind of gets you to an equilibrium. Or a different equilibrium. Yeah,
maybe it releases some endorphin or something like that. I don't know the proposed hypothesis for how cussing could help with pain.
I like it, though.
When we watch people, they say, it works.
I would like to give my own self opinion on that, and I would agree with that completely. Swearing definitely helps me.
Supported by anecdote. Yeah. Hell yeah.
See, I already feel better now. Okay, so let's chat a little bit about the different types of pain that are out there, and then we can go from there.
Okay.
So tell me, what are the different types of pain that are out there?
So I guess I'll since this is a psychiatrist, I'll start with grief.
It's a good place to start.
Yeah, there's emotional pain.
Yeah.
And so grief or loss is one, and then there's kind of guilt or compunction, that distress you feel when you feel as though you've done wrong.
Yeah.
It's another one. Worry. And then there's like melancholy. So that's not necessarily like grief or loss of another one, but like this
apathy.
So melancholy is not apathy, because apathy would be the lack of emotion.
Oh yeah, okay, that's true.
So this is just like a like somber, depressing, like sad state.
Lack of hope.
Yes.
Okay.
Correct. Yeah, it's this like pit of hopelessness.
that whole basket is a chronic illness patient's like sidekick.
Yeah, exactly. So those are all types of pain that can be treated with compassion,
Right.
And validation, affirmation, and therapy, and like obviously our whole battery of medications. And then as far as like the physical types of pain, so there's, like we mentioned, there's like kind of mechanical or arthritic pain. So this is things that ache.
Yeah, the crunchy pain.
Yeah, like if I were to punch you, like
Yeah.
it'd be kind of fall within that. And then there's kind of like fiery tingling pain.
Yep.
This would be like more like neuropathic pain.
Yep.
And
The
then
lovely CRPS.
yeah.
We love that.
And then I think those are like clinically like the best ones that I could describe. But then there's other like, I'm trying to like classify the source of like discomfort, which is like something we see in like akathisia or like restless leg syndrome, which is like
Can't get comfy ever.
yeah the inability to feel comfort. So it's something like you're in active discomfort, but you almost like need to constantly be like relieving that.
Yeah.
And I think that
Does that have like a
argued as
large
another source of pain.
psychosomatic component, do you think?
I'm not sure, actually.
In my mind, that would make sense. Mm-hmm. I find like if I'm having a long stretch of pain buildup, I'm more likely to like toss and turn all night. And then it's like, oh, I'm anxious, I'm not going to sleep. And then I'm tossing and turning and can never get comfortable.
Yeah. And I think ultimately these things sit in a spider web with each other.
It's
They're all
definitely
very
not black and white
interrelated.
at all.
Yeah.
And nothing is separated into clean little buckets.
Yeah. And,
Just like medical school teaching into real life.
yeah. And I think that's like the thesis of this podcast is that there is a kaleidoscope of different types of pain, and they all sit on each other in this web of sticks and
look different in every single person.
Yeah. And so I think like even just like kind of like saying the word pain, it ultimately doesn't do a great job of like capturing what someone's experiencing.
Yeah, I agree.
And so maybe it just means like, as we try to like look into our discomfort, say like, okay, like what category does this fall into? Like how do I name what I'm feeling as like a chronic pain patient? Even like I'm feeling like physical discomfort, but I'm also feeling this, and I'm also feeling this. So like these are like my sources of anguish, you know, rather than just I'm in pain.
Yeah.
Which it's tough. It's hard to figure out like what pain means.
Yeah, I think it makes it really hard to communicate with other people that are then trying to help you when you're just saying I'm in pain, which when you are in a lot of pain, it's very hard to then take on that responsibility to like break it down into all these different things.
Oh yeah.
But you have to.
Yeah, it takes a lot of effort too.
Oh yeah. But you have to if you want to get the proper treatment that you need. Like if you are having CRPS pain and you're just saying I'm in pain and first line of action is Tylenol, like, yeah, no shit, that's not going to help you. But the burden is on you to say I'm having tingling, burning. It feels like my entire body is on fire right now.
Yeah.
Here's what my history looks like in order to get the right treatment that you need.
Yeah. And that's really helpful. Like when that is like description is given, that helps us a lot in kind of navigating it too.
So maybe our like boiled down points out of that is when you are in pain and are in a setting looking for help, it's one, humanizing yourself and being vulnerable and feeling like
which is
it's hard
hard
to do.
in and of itself. Yeah.
It's hard to do. But if you can do it, like what are the two outcomes? Someone's going to not believe you or someone is. And that's also the same outcome if you aren't vulnerable. So if you're vulnerable and say like, I've been trying, I can't try alone by myself and I need help, and then can also take that leap to take the time to explain, here's the feeling of these different types of pain that I'm having right now, or the one pain that I'm having right now. Here's my medical history. Here's what's helped me. That could be a better outcome or experience for you.
And I think like these providers at the end of the day want to help patients the best they can.
It's
And
a lot of work to be a doctor.
And they want to treat these symptoms. And I think it's hard when their only symptom is pain. But if their symptom is like, I'm in discomfort, but it's like, I'm nauseous, my fingers are burning, and I'm feeling a lot of worry.
Yeah.
Now we can, like, you can work with that. We have a menu to order off of.
Yeah,
like,
we do.
I can give you medicine to help with your nausea. I can help with your tingling and your burning, and I can try to give you something to help with the worry.
Yeah. And then you might feel a little bit better and can continue figuring out what's going on.
And each of those things are going to, like we said before, interact with each other. Yeah.
Yeah. Okay, so this is rewinding. I like sometimes ping pong on conversations.
Okay, yeah.
Chronic pain brain. It's really nice. You can keep a straight thought all the time. We were talking about like the mental anguish part. So when you have a chronic illness, that's such a huge component. And I think from posting online and hearing other people's stories, that is usually put as second to address. It's not their primary thing to work on. Growing up sick, I had a totally different perspective of that, of like, I have to handle both of these things at the same time, otherwise I won't get better. And I think that's because I was trying to tough both of them out for such a long time. So when I finally like talked to somebody and they said, hey, these are both important, I was like, oh, I finally have permission to try to feel better. So how does a chronic illness patient go about addressing and looking at the mental anguish component of their disease?
So I think what you're getting at is like kind of like saying or understanding that like anxiety, depression, other like psychiatric illnesses can run along these chronic illnesses. And
more often than not.
Often, yeah, I mean, we know it as a risk factor.
Yeah.
And so people will see the label of anxiety or depression as a dismissive one sometimes.
Yes.
So I think this is like,
which is a bummer.
Yeah, it sucks, and it's because it has been used to dismiss pain. First of all,
yes.
So the reason where that comes from is people that don't do thorough evaluations of pain will readily call it anxiety, and then that gets communicated to them is if I'm saying this is anxiety, I'm not listening to you, I'm invalidating you.
Yeah.
The problem is you can do very thorough investigations of some kind of discomfort and realize that it is anxiety.
100%.
And that doesn't make it less important. And it doesn't make it
Correct.
less of a problem for you. It just means we have to target the anxiety. So,
as well.
Right.
Yes.
So, and that as well is kind of what I'm getting at, which is you have to find a way to say both and that these things aren't mutually exclusive. That I can have this chronic illness, I can have chronic pain, and also I have anxiety.
Yeah.
And
which is not that shocking when you like look at what someone deals with a chronic illness.
Yeah.
Like, no shit, you're dealing with some mental anguish.
And who wouldn't?
Yes.
Right? And so the other thing that I want to point out is sometimes people will have this feeling that like, okay, my chronic pain is not my fault, but like if I become anxious or depressed because of it,
that's my fault.
Then I'm weak.
Yeah.
And so I guess the analogy I use for a lot of people is that it's just because it's like it's not your fault and this is a normal reaction to what's happening.
Yeah.
Doesn't mean that we can't treat it. And so the analogy I say is like a normal reaction to getting hit by a car is your bones breaking. Like I agree, yeah, it's a normal reaction. We still need to splint your leg though.
Yes.
And then I'll say like, so what your mind has basically been through is like a 6-car pileup, and we need to fix your mind like we're fixing your body.
Yeah, and if you do that, you will feel a little bit better.
And so like I try to kind of separate people from like their identity from their mind, and brain is helpful for a lot of that.
Ooh, okay.
Your brain is hyperactive and it's reacting to all these things, and it's sending these worry signals to you, the operator of your brain. Let's find a way to kind of diminish some of these worrying signals.
Okay. And how do patients usually respond to that?
Pretty well. Yeah, because like while we all are our brain, we are more complex than that.
Yes.
And it's weird to kind of like, it becomes like very philosophical very fast, I guess. To be like, yeah, you are all of your neurons in your brain, but like this part of your brain, not you, this specific part of your brain,
just like your organ,
it's acting kind of weird, so we're going to address it. And I think like that, I find that to be like overall helpful.
I think so, because then it strips you away from like, I'm in control of this.
Yeah, and while it was always not their fault, it kind of helps them have kind of tools to organize it in their head. It's like, yeah, this is
not my fault.
It's not me. It's not my weakness. It's my brain that's screwing up.
Yes.
And that's how I see it too. And then that's how even people that don't have chronic pain, that's how I explain a lot of their mental illnesses.
I think that's exactly when I realized that I had, it was not realized. accepted that I had anxiety from childhood, to be clear. Had my first panic attack at like age 3 or 4 in a butterfly garden because a butterfly landed on me, which is an abnormal response to have a panic attack from that. Did not accept that I was an anxious, anxiety-prone human being until much later in life when a doctor sat me down and was like, you're experiencing anxiety on a daily basis, and that is compounding to how you're experiencing all of your autoimmune conditions. Let's try to work on that and see how that impacts everything else. And it was like light bulb turned on.
Yeah, exactly. And it's crazy, like anxiety that you're experiencing, I try to almost classify it as like another bodily symptom that you're feeling. Because in a way, like not to bring you into one of my therapy sessions, but
let's do it. I'm ready.
Like I want you to try to will happiness onto yourself right now. Like will like joy.
Do I look joyful now?
Make yourself as joyful as possible. Okay, now make yourself as sad as possible.
I don't like that part.
Did you do it?
Yeah.
Okay. How did you do it?
I just thought about something sad that happened.
So you thought about something sad, and that made you, so you controlled your thoughts, but you didn't control your emotions, right?
Correct.
You changed your thought and then had a natural reaction to that thought.
Yes.
So just like how I can't will pain onto myself, I can't make myself feel a burning pain just by willing it. I can put my hand in the stove, like I can control my arm and put it in a situation where it will feel pain. I can control my thoughts and put them in a situation where I'll feel an emotion, but I can't will that emotion directly onto me.
This is a great way to explain this.
And ultimately, you and I, neither of us are control of our emotions. They are responses, physical responses that our body feels to things. That they feel to thoughts, they feel to situations, to anything else. So if I'm explaining depression, I'm saying there's a malfunction in the way that your body's processing emotions. It's not allowing you to feel happiness. Just like you can't feel something else. You can think about anything under the sun, but you literally, like, your body cannot feel that.
Right.
So that's why we need to treat it. It's not you. Like, you're the agent who has control of your thoughts, but you don't even have control over all of your thoughts.
No.
Like, think about like a monkey banging cymbals on top of a palm tree right now.
I'm thinking about that, and also this Olipop, and also like 25 other things.
So now I want you to not think about a Cybertruck.
Fuck you.
Yeah, you probably thought about a Cybertruck. Yeah, so
and a raccoon.
You have control of some of your thoughts, but you didn't control that one, obviously.
Failure.
So you can't control your emotions at all. You have partial control of your thoughts, and you hopefully have control over your actions. So
Lord hope so.
So if you can get someone to acknowledge, like, wait, it's not my fault I feel an emotion. I don't have control over my emotions, so then I can treat my emotions just like I treat other forms of discomfort, then like that's kind of how I sell that pitch to get people to understand that, like, they're not responsible for their anxiety, that worry. You're not worrying because you're weak.
No.
You're just a normal human who's just getting worry getting sent to you by your amygdala.
Yes. God damn it, amygdala.
That sucks. Yeah.
Somebody talked to that thing.
Right.
Okay, so when you are talking with these patients, then what's like your next step? So you do the sales pitch, let's say. Let's call it that. I kind of let that.
Yeah, sure. We call it the sales pitch.
So
that we talk about warranty. I give them a couple different models. We do some test drives.
Some insurances. Yeah, good.
I
can offer you a really good discount too.
So the next thing I go to is I say, so it turns out that if we increase the amount of serotonin in your synapses, it decreases the amount of worry we get. And then I love to bring in animals when I have this discussion, because I think animals can kind of sidestep placebo, because a beta fish isn't going to anticipate how an antidepressant is going to affect it. It's just kind of reacting to what's around it. That's fair. You know what I mean? And so there's this study I saw. It's one of my favorite studies. They put Prozac. They dripped Prozac into these tanks with beta fish. And the beta fish, like, they're very aggressive.
So
animals,
aggressive,
right?
yeah.
So they like they tracked their aggression signals, and they'll like flare their gills, or they'll like pop their eyes and do something to get like angry with each other. Yeah. And like there was a dose dependent relationship between how much Prozac they dripped into the tank and how many less aggression signals the beta fish were putting off at each other.
What?
And yeah. And the same thing for like birds. If birds are stressed and they're plucking feathers, in these like anxiety inducing environments for them, if you give them paroxetine, birds will like you can count how many less feathers they're plucking, and they start to alleviate their anxiety. And the bird isn't going to anticipate like, oh, this pill you're giving me among my feed is like what's helping. But
no.
What we do see is that and it's really hard to make these conclusions, but the relationship between agitation or anxiety and serotonin is actually like one of the more robust ones we have in neuroscience, which is where when serotonin goes up, anxiety and agitation goes down, and vice versa.
Always?
Pretty much. So
Cool.
So like the serotonin hypothesis of depression has been kind of debunked, that low levels of serotonin contribute to depression, but
Okay.
we have seen like low levels of serotonin in people that are more prone to agitation and that, or anxiety, and that
Yeah.
when you increase the level of serotonin, then that actually starts to fix itself. So, well, I'll bring up the kind of the beta fish example and say, like, just what I said to you, serotonin is connected decently well to agitation.
Yeah.
And what you're experiencing when you're angry or having fear, a lot of that is anxiety.
100%. And now it makes sense why, like, if you're taking a narcotic, which increases your serotonin, I think.
Actually, I don't know. So I know mu opiate activation increases dopamine, but I can't say for sure if it increases serotonin.
Oh, okay. Well, how it's
Sorry.
gonna go on a... I was like, look at this! I just figured everything out!
And you might be right, and it might be really cool. I just don't know enough to confirm it, and I try really hard to say things that I know are true.
I mean, that's very honorable of you, I guess. I just spew everything.
But that could be a lead, yeah. And I'll read about it.
You're welcome. Does the NIH call me, or do I call them?
And then there's other ways to decrease agitation, because you could also just like hit the whole system with a benzo, which is gonna like
True.
It's just gonna lower the voltage on
all.
everything. Yep,
Yeah,
exactly. But yeah, so I'll kind of say that, and then be like, you know, is this something that you want to try? And then when you frame it like that, rather than, hey, you're anxious, here's an anti-anxiety pill, I think it helps people kind of medicalize their condition a little bit more, and then be a lot more willing to take it.
That's okay. What you just said, medicalize their condition. That is such a key word to me, because it puts my mental health in the same bucket as my physical health then. Mm-hmm.
But,
which it is, but I think a lot of
it
people
was
separate
always
them.
Physical health. Like,
Yeah.
my point is, like, we have so little insight into like the code that goes on inside of our brain, and
we don't
we're
know that
very
much about
limited
that
by the
part.
ways that we try to picture it. Okay, sorry, I got a little heated there.
Would you like to take a sip of your Olipop? Are you feeling agitated?
Yeah, I think I think it was the espresso. Because it was funny, dopamine, too much dopamine can make you agitated. To norepinephrine too, yeah.
So there's a cliff.
What do you mean?
Like, if you're dopamine chasing at a certain point, you're going to cliff dive. And it's going to be
Into
counterproductive.
agitation?
Yeah.
Oh, yeah. And I mean, like, I think when people say, like, oh, I'm just trying to get my dopamine hit, or I'm dopamine chasing, like, they're not actually increasing their dopamine levels. It's just, this has just become, like,
Trendy.
kind of like, yeah, a pop psych term. Like a lot of times you're probably trying to, like, seek an emotion or something like
joy.
that. Yeah.
I'm always trying to find joy.
The only reason people scroll on their phones because they want to feel something. And we call it a dopamine hit, but like, do you want to laugh? Yeah. So then you'll feel joy.
Yeah.
Or maybe, or you don't want to feel like this emptiness that you have. So you're like, okay, well, like now I get to watch a video of like soldiers coming home to their kids or to their dogs. And now I can cry, so I can feel sadness, or I can feel anger, you know, or I can feel curiosity, or I can feel comfort.
Yes.
Those aren't all like stimulating dopamine in your brain. These are just like different things that help like supplement the human experience, because you're craving connection and you can't find it. So you're like, I better outsource it to my fucking timeline.
I'm going to outsource my connection. Yeah, that also is like a plague in the chronic illness community, because you get cut off from hanging out with people.
Okay, so I have to ask you this about the chronic illness community.
Okay.
How do you deal with like chronic pain Olympics or like illness Olympics?
Crazy. I hate
Because
it.
I'm
pisses me
100% on the outside of this, but
Yeah.
I kind of see some of these like intergroup dynamics happen.
Yeah. So I want to break it down into two different things.
Okay.
Because it's not as easy, obviously, as just pain or sickness Olympics. It's also, I am right about the way I'm treating my pain or my illness. And that, I think, comes from a place of deep insecurity of what if this isn't the right way, and what if I'm doing something wrong in handling and not getting better. So I think it all comes from a place of like tied so deeply into your identity of you being in control and responsible for your experience with pain or sickness. And so when somebody, like if I post, man, I'm having a really tough day with my pain, and someone's like, well, I just had 5 bones break and also my brain is open right now. That's just because they are like super insecure with their identity of being sick, I think.
Yeah. Do you think it's like a plea for power? Like,
yeah, it's a plea for control.
My suffering is my power.
I think it's
and I lose that power if I no longer suffer, so I have to be suffering more than everyone else.
I don't think it's power. I think it's control, which maybe those things are interrelated.
Yeah, actually, so I guess you could say like to use your finance language, suffering is our capital.
Oh, it is our capital, and how we interact with each other online is to share. It's to share our suffering with one another.
Yeah, and
then the people that are like really fucking going through it and are super isolated. I think I don't want to assume bad intent, because I think sometimes too, it's like, I have been isolated for so long, I no longer know how to interact with people in a normal way. And when so if we bifurcate those two things, the person that is so isolated doesn't remember how to interact with people in a normal way. Theirs is, I have a really rare disease and I had this really rare procedure done. The word rare is used every third word.
Really?
Yes. And then there's the person that's like, I'm so unsure of my health, how it's being managed, and my impact to it, that I have to assert control over somebody else to make myself feel better about how I'm handling everything.
Interesting. Rare.
Yeah.
Why it's so important that it's rare?
It's a validation of your identity and your struggle of not being heard for a really long time, I think.
Yeah, I think so too.
Like, I have a rare disease. I very rarely say I have a rare disease. I just say I have polyarteritis nodosa. And to whoever knows what that is, they're like, yeah, that's not the most common type of vasculitis. It's not important to me that people know if it's rare or not. What's important to me is that people know that I'm autoimmune, and I want to make a foundation to connect with people on being autoimmune.
So I'm really curious about your opinion with this, because these behaviors we're seeing, they are, on one hand, like we said, kind of pleas for power or control, but they're also like community seeking. And I think it comes out of like a misunderstanding of how to build relationships. Like you said, the only way they know how to interact with humans is when they're receiving sympathy and they're kind of the identified patient.
Yep. I think that's really wise. I think probably people are scared of that because their identity gets so warped into being sick.
That's tough.
And that's also, like, it's from what we were talking about earlier. Like, if you get constantly told you're not sick, you're not sick, you're not sick, it's just anxiety. You feel like you have to overprove your pain or your illness. That becomes easily your entire identity, because you're working every single day to prove yourself that you're sick enough for treatment to your friends, your family, your colleagues.
Yeah, it's like bi-directional sales.
Yeah.
Like you're trying to sell your illness, trying to sell your pain. We're trying to sell medicines, trying to sell diagnoses.
Yeah.
Trying to sell care plans.
But I think
it's a business meeting. You shouldn't say like healthcare shouldn't feel like, but it is a business meeting.
It is a business meeting.
And like it's a surprisingly apt lens to view it that way.
I actually think it's a great way to view it. It also takes the emotion out of it. Like when you asked me earlier, have you ever like been frustrated with a doctor or felt anxious from an interaction or something? Like, if you can view it as it's not me that they're talking about, it's my disease, and you're separating who you are from your disease, then all of a sudden if your doctor's like, I want you to try this more, it's not like you're not trying hard enough, you're being a little bitch. It's your disease hasn't had enough time to catch up to this medication. Let's keep going.
Yeah, I'm just a consultant for your disease. It's funny you should say that. Like, I try to personify those things for some of my therapy patients. Like, they'll talk about like kind of their negative self-talk or the voice in their head that will like tell them things, and I try to come up with names for it.
I love that. Tell me some of them. I have that as well. I call my prednisone version Veronica, and she's a bitch.
I'm not going to tell you the names because I don't want any of those patients to watch that and be like, hey, that's mine. But I usually
HIPAA, okay?
Yeah, I usually try to keep them silly, like Stuart, you know.
That's a great name for something.
So like we'll try to do like mindfulness, and then I'm like, you know, where did your mind go? And they're like, oh, I just kept thinking about how like I wasn't good enough, I didn't deserve my promotion, or you know, I knew this bad thing was going to happen. I was like, did Stuart say that? And they're like, yeah. It takes some of the power away from it.
Yeah.
And also, like, just get a name to it. Yeah. So
separation of church and state, baby.
Yeah. Do you have a name for your
depression?
Polyarteritis nodosa?
No, just prednisone. Prednisone Alex. That's it. Maybe I should name the PAN though.
Yeah. You could name the individual nodules.
I love that. I just got one biopsied, so I just cut one out. She gone.
You can put on a necklace.
Oh, like those chain ones.
These
are all my children.
These are my scalps.
These are my trophies.
I wear it to scare the rest of them.
Yeah, keep in fucking line.
So they know not to act up.
That's pretty funny. I like that. The way I like to wrap the show, you're not off the hook yet.
Okay.
It's called the one brain cell segment. So
we've been doing the 2 brain cells.
Shockingly, there have been 2 so far.
It's time to downgrade.
Yes. Now it's just you because you're losing my brain cell.
Okay.
I'm going to give you a quiz. I'm just kidding. I'm not going to give you a quiz.
Okay. I'm ready for a quiz.
Okay. What is... I have nothing to ask you. My brain just went blank when I tried to be funny. It was
I took
cute.
the brain cell already. That's why.
Yeah. Thank you. You needed that. Okay. What is your favorite TV show or movie to unwind with when you're like fucking exhausted? You just worked a 24 plus hour shift and you need your one brain cell to be entertained. You're welcome.
So, okay, I have 2 answers to this question because I've been playing a video game recently.
Ooh, which one?
Like that. It's called Manor Lords, and it's like Sims, but for like building like a feudal environment. So like I shit you not, you start out with just like a bunch of homeless, homeless like peasants. Lovely. And like wood, and you have to build like little feudal plots, and you can like give them chickens, or you like help them farm, make vegetable plots, and then it has a whole like living, breathing economy in this like land that you're the lord of. So like you have to
this is like, Farmville plus Civilization.
Yeah, you have to like fallow fields, which I've been learning about, and like
how are you at fallowing the fields?
I mean, I don't do. They do it. I just tell
you're
them
their lord,
to.
Sorry.
Like, you get this field fallowed bitch. But it turns out, so you can like unlock technology as you grow as a civilization. So like you unlock like the ox plow at some point.
That's huge.
Which, oh my god, dude. The amount of labor that saves, because it takes like 6 families to plow this fucking field. Now one dude and an ox can knock it out.
And it was a big change and upgrade for civilization.
And I was fucking up for a long time because I would make my farm fields like squares.
Oh no.
But you want long, skinny, like
for the ox
rectangles. Exactly. You need to minimize turns with the ox. And if you actually, and so if you
clearly didn't grow up in Indiana. If you look
in medieval England, all the plots are long and skinny like that. And I was like, oh shit.
That's why.
This is how you do it. Okay. So I just will consult history a lot of times because like they figured out.
Are you cheating for your game?
I guess. Yeah. I'm using outside resources, but they've already lived through it. So who fucking cares, right?
I mean, you're supposed to be playing from ground zero. You're not supposed to know about any of these things.
Just figure it out. But anyways, like,
take some more espresso and try to noggin your way through that one, Preston.
But if I'm not doing that, I'm watching BoJack Horseman.
Oh, great show! I
love that show so much.
Adult, not comedies, adult
cartoons.
Yeah, thank you. Brain just went full half brain cell. Adult cartoons are hands down my favorite thing. I
can comfort rewatch most episodes.
Yep.
BoJack Hates the Troops is probably one of my favorite ones.
Great one. Yes. Are you Bob's Burgers?
I haven't watched Bob's Burgers, but I've been recommended several times. I heard I would like it.
I will play the game if you watch an episode of Bob's.
Okay.
Deal?
Yeah. That sounds good. Then you have to come on our podcast and we'll debrief.
Okay, that sounds good. I'm going to spend the next 72 hours playing this game and make it my entire personality.
I'll text you the links.
Fuck yeah. All of my content is about to be feudal times.
Yeah, it's pretty cool, honestly.
Well, this has been an excellent chat. Thank you for being on my pod.
Oh, of course. Thanks for having me.
Yeah, thanks for also the free therapy session. That was nice. I feel like I really made some headways. Am I your favorite patient?
Anytime. Yeah. But it was really fun coming out here and seeing your studio, and thanks so much for having me.
Yeah, likewise. Thanks. And that's a wrap. Thank you so much for joining me for another week of Calling in Sick. As a reminder, I would love for y'all to like, follow, subscribe, save, share with a friend, do all of the things. It truly helps grow this community, and it helps these episodes reach the people that need them the most, whether that's for an educational piece, to have a little laugh, or to not feel so alone. As a reminder, Calling in Sick sits on YouTube, Apple, and Spotify, and anywhere else where you can find your listens. From the bottom of my heart, I absolutely love you guys. Thank you so much for calling in sick with me every Monday. It's been an honor and a pleasure so far, and I can't wait to continue. I can't wait to continue building this community with y'all. Love you.